Welcome to The Idea from Harvard Business Review. I'm Adi Ignatius, Editor-in-Chief, and joining me today are Harvard Business School professors Robert Kaplan and Michael Porter to talk about how to solve the cost crisis in healthcare. Mike, let me start with you. What is the problem you're trying to solve?
Well, Adi, as you know, costs in healthcare are out of control all over the world, not just in the United States. An enormous share of our GDP is tied up in healthcare. It's growing every year. A lot of these problems, some of the problem has to do with aging populations and medical technology, but what we've discovered is actually a major part of the problem is incredibly surprising, and that is that organizations in healthcare don't know how to measure their costs properly. They confuse cost with how much they get paid. They add up cost around departments, not around the patient and the patient's need and meeting the patient's need. They allocate cost improperly with all kinds of biases that really confuse what the actual costs are. And because of this, efforts in the past at cost reduction in healthcare have been completely ineffective. Across-the-board price cuts when that makes no sense, sort of arbitrary reductions in services where that makes no sense, and really the inability to get visibility on the things that could really make the system more productive.
Let me just add one more dimension to what Mike said. To the problem is that people don't even agree on what they mean by costs. When the government talks about costs, they mean their costs, what they have to spend to reimburse providers. And so when they talk about reducing costs, they mean how can we starve the beast and reduce the payments into the system. Consumers think about their costs, what it costs them to get medical care or to pay for their insurance. But the correct definition of cost is the costs incurred within the system by the provider organizations themselves. And the only way to get fundamental reform is to work on the costs within that system and solving the problems that Mike described.
Okay, so how do we fix it?
Well, the solution actually is not that complex. The framework is simple, though it did take me 20 years to get it this simple. And it focuses on the patient as the unit of analysis. It's the patient that's triggering the demand for all these medical resources. And so that has to be your fundamental costing unit. And we get at it in a two-stage procedure. One is to just look at the administrative and clinical processes that a patient goes through over a complete cycle of care, when they first present with symptoms, until the conclusion of their care. And just map all the processes that are involved in that and identify the resources, which are the physicians and the nurses and the administrators, but also the equipment and the facilities that are used at treating the patient at each of these processes. And the second part is just to measure the cost of each of these resources. What does it cost to supply a physician, a nurse, a clerk, a piece of equipment? And then you measure how much time that the patient spends with each of these resources, multiplies that by the cost, and that gives you the cost over a complete cycle of care.
And some of the powerful things we've learned is you have to do that measurement around a set of patients with a given medical condition. So you want to understand the cost of treating breast cancer or diabetes, rather than accumulate the cost of providing a particular service like an outpatient visit or an image. And when you do it around the patient's medical condition, then you can compare the cost to the outcomes and start asking value questions. And are we creating value? Do we need to do this process in order to improve the outcome? And that discussion, as astonishing as you would believe, has never happened in healthcare. There's never been the information to have that discussion that really compares costs and outcomes.
So this sounds like a great plan if you were building a healthcare system from the ground up. Let's talk practical. I mean, how would you reform a system like the one in the U.S. with its messy, that has entrenched interest? How would you change it to be more like this?
What we have found is that the process of just going through doing the process maps and agreeing which resources are done at which process and what does it cost to supply the resource, this is not controversial. I mean, you can get back to the data, and it actually has provided a great forum by which these warring factions, administrators saying cut costs and clinicians saying, hey, we cure and save patients, start to speak the same language. And so the transformation will come from within. It's going to come from within these various provider organizations, because this is what they should be doing and should have been doing. And it's kind of obvious. I mean, we found that the clinicians buy into this because it corresponds to what they're doing. There's also pressure, of course, from the outside, from various insurance companies and from the government to cut the payments. And the only way these forces are going to come together is if the provider organizations get more efficient, get more focused, and deliver the same or better care at lower cost, because their reimbursements are not going to continue to escalate the way they have over the past several decades.
Adi, you know, I've been working now for about a decade in healthcare, and this article is the most optimistic single thing about healthcare that certainly I've ever done, because it really shows that we can make tremendous improvements in caring for patients and do it with a lot less resources, and nobody intrinsically has to take a pay cut. And so many people feel that the healthcare problem is intractable, the cost problem is intractable, it's driven by forces beyond our control. It actually isn't. We can actually solve this problem.
And what would this do? Do you have any estimate, a system like this rolled out across the U.S., what would that do in terms of healthcare, in terms of overall costs?
Given the state of the industry today and its lack of understanding of the cost of doing business, having this clear, transparent, and actionable view on what it's costing them to deliver care, where the unused capacity is, where we're using the wrong medical resources to treat a given condition, doing things in expensive facilities rather than in much less expensive suburban clinics, I'd be surprised if we couldn't get at least 10 or 20% of the costs out of the system without sacrificing outcomes, and as Mike was saying on the cycle times, actually improving outcomes at the same time.
I know that you've been involved in some pilot projects, and I'd love to know briefly what you're finding from that.
We're currently working with 7 or 8 pilot sites, about half of which are focused on the same procedure, which is a total knee replacement. And so we have the opportunity of seeing the different processes they're using, the different resources they're using at each of these processes, and compare their outcomes and costs. The clinic that we're working with in Germany, is able to deliver comparable outcomes to the U.S. and using 25% of the resources. Now, some of that is actually prices. They're paying a little bit less for their nurses and the physicians than we do in the U.S., but there are productivity differences of somewhere between 2 to 4 to 1, just in the way they're organizing the delivery of medical care.
Yeah, we are facing now a very growing demand for more and more pilots. So I think the healthcare field is ready for this. This is the moment. The circumstances are right, and the challenge now is to help make this actionable, help make it as easy as possible to implement, help provide the tools and the support to allow organizations to actually implement this. But 10 years from now, every major healthcare delivery organization is going to do this. They have to.
So it's very intriguing to me that the two of you have come together on this topic. Can you tell me a little bit about how this collaboration came about?
Well, I stumbled into this field perhaps a decade ago, really because a colleague of mine had a child that was extremely sick. And I spent day after day after day talking with her about her child and what was going on to him as he was migrating his way through the healthcare system. And we started getting interested in it and talking about it, and that led to some work. And so I've been at this for a while, but I had never gotten close enough to really understand this cost issue until perhaps 2 years ago, when I started asking questions that seemed obvious to me that nobody could ever answer, like, oh, what's the cost of doing this service in this facility versus that facility? And everybody would, clear their throat and wave their hands, but they really didn't know. And so I got this hunch and asked Bob if he had ever done any work on costing in healthcare, and he said, well, he'd been close to doing work, but had never quite had a chance to really get under the tent in a real important organization. I had some great relationships with some leading medical centers, and so we just agreed that we would give this a shot. And it's just been enormously gratifying to work with Bob, and the rate of progress here has been really breathtaking.
That was fascinating. I want to thank both of you for being with us today. That was The Idea from Harvard Business Review. For more, go to hbr.org.